Hello everyone, a very good morning. Today let's discuss on our NEET PG previous year questions. So we'll make this into two video session or as a three-part session also because we have nearly around 65 questions I have made it here from this past 5 years question and mainly the important topics and the repeated topics we are going to discuss it here. Short, you will be getting at least 2 to 3 questions from this previous year topics. Okay. Yes. Going on to our first question. So, what is true about your septal hematoma? Whether first option, whether it crosses the suture line. Second option, always present at birth. Third option, forceps delivery is a risk factor. And fourth option is all of the above. Yes. In birth injuries, you have septal hematoma, caput succinylum, and your subgaleal hemorrhage. These three topics are very important for your NEET PG previous year question. So going on with the detailed discussion of your septal hematoma and the caput succinylum. I'll be a bit fast in this video because it is already a revision session only. Okay. Yes. First, what is caput succinylum and what is the cause of your caput? So caput cause is because of the prolonged labor. So when there is, when the child's head and the baby's head is in a vaginal canal for a prolonged period of a time, what will happen? The veins that is present in the scalp, there will be an increased hydrostatic pressure. So the veins that is present in the scalp will have an increased hydrostatic pressure. Due to the increased hydrostatic pressure, what will happen? All your interstitial fluid will come into your subcutaneous plane. So there will be a seepage of your interstitial fluid into your subcutaneous plane, which is the reason for your caput succinylum. So the collection here is a serosanguinous fluid. Okay. What is the location of your caput? It is always in your subcutaneous plane. Next. Its appearance is present at the birth and maximum size also will be present at the birth. It resolves by around 2 to 8 days. You can remember it by 2 to 8 days and it crosses the suture line. Why we are defining that it crosses the suture line? Because when you see the layer of the scalp, first one is your skin layer. So you know the mnemonic, right? S-C-A-L-P. That is your skin. Second is your connective tissue. Third is your aponeurotic layer. Fourth is your loose areolar tissue. And fifth is your P, is your periosteum. So this caput occurs in a subcutaneous layer. Since it occurs in a subcutaneous layer, it crosses the suture line. This is your suture line. So it will be able to cross your suture line. While coming to your septal hematoma, it is in your subperiosteal layer. Since it is in the subperiosteal layer, it cannot cross the suture line. It is a well-defined swelling and it has a distinct margins also. So we'll talk about septal hematoma now. So what is the cause of your septal hematoma? It occurs because of a trauma during your labor. So when there is a trauma during the labor, there is a rupture of your dipolic veins. And there is a collection of what? Blood. So collection mainly is your blood. In which layer it is in? It is in your subperiosteal layer. Okay. So maximum size will occur only by 12 to 24 hours after the birth. And it resolves by around 2 to 8 weeks. So you can remember it like this. This caput will resolve by around 2 to 8 days, while your septal hematoma will resolve by around 2 to 8 weeks. Okay. And this doesn't, since it is in the subperiosteal layer, it will not cross your suture line. It is mainly associated with your linear skull fracture, hyperbilirubinemia. Why we are telling it as hyper? Why it is associated with hyperbilirubinemia? Because the collection mainly here is blood. So when the RBCs that is present in your septal hematoma will get break down, it will lead on to your increase in your physiological jaundice. So the child will have a hyperbilirubinemia here. So going back to our question once again. So what is the answer here? True about septal hematoma. Forceps delivery is a risk factor for your septal hematoma is the answer for this. Because a trauma during the labor can occur because of your forceps delivery also. So forceps delivery is a risk factor. So whether this septal hematoma is always present at the birth? No, it is not always present at the birth. Maximum size will occur only by 12 to 24 hours. It crosses the suture line? No, it will not cross the suture line since it is in a subperiosteal layer. So these are the important points you need to know about your cephalohematoma and your Caput's accident. That is enough. Okay. Yes. Going on to a image. So this is your caput. This child is having caput. Why it is caput here? Because this child is a very newborn child. It is he or she he is having a maximum size present at the birth itself. One. Second reason for this is your cephalhematoma. Why this is your cephalhematoma? Because it is a very distinct swelling and this child is somewhat well dressed and all. So it is present at after 12 to 24 hours after the birth. It is cephalhematoma. Okay, these are the images. Next, going on to your second question. Here, a premature infant delivered at 32 weeks present with a respiratory distress after the birth. Which of the following is deficient in him? So, option A is dipalmitoyl phosphatidylcholine. Option 2 is dipalmitoyl ethanolamine. Option 3 is pingomyelin. And option 4 is cardiolipin. Here, a premature infant at 32 weeks having a respiratory distress. What is the diagnosis? It is mainly a respiratory distress syndrome. That is your hyaline membrane disease. Right? So in a child with a respiratory distress syndrome, what will be deficient? The surfactant will be deficient. What are the components of so to know the exact pathology behind it, you have to know the components of the surfactant. Then only you can answer this question, right? Yes. So when do you call a child to have a respiratory distress? So when any of these two following is being present, you call the child to have a respiratory distress. That is, when the child is having a respiratory rate of more than 60 per minute, or when the child is having chest retraction or indrawing, or when the child is having grunting or cyanosis, then you call the child to have a respiratory distress. The most common cause in a preterm child with respiratory distress is your RDS, that is respiratory distress syndrome. In term child, it is your TTNP, that is transient tachypnea of newborn. Okay, next. So we have two scoring system for our respiratory distress. One is our Silverman-Anderson scoring. This was your this entrance exam, the innocent entrance exam question. Your Silverman-Anderson scoring. Another one is your Downey scoring. So what are the components in your what is this thing belong to your Downey scoring? Was your question, right? So this is also an important topic in which we can get the questions. So Silverman-Anderson scoring is mainly used for a preterm child with a respiratory distress, while Downey scoring is mainly used for a term child with respiratory distress. Why we are using these scoring? Because we segregate or we interpret the child to have either mild, moderate or severe respiratory distress, and the treatment varies according to the scoring system, right? Yes. Coming to the surfactant. Surfactant is produced by your type 2 pneumocytes, and it appears in the fetal lung by 20 weeks of gestation and in amniotic fluid by 28 to 32 weeks of gestation. The mature level is present by around 35 weeks of gestation. So what are the components of your surfactant? One is your dipalmitoyl phosphatidylcholine, that is nothing but your lecithin. Second one is your phosphatidylglycerol. Third one is your apoprotein, and fourth one is your cholesterol. So these are the four main components of your surfactant. In this, among these four components, your dipalmitoyl phosphatidylcholine or this lecithin is the main component. So they can ask which of the following is being deficient is the question right here. Yes. So they can ask either as dipalmitoyl phosphatidylcholine or they can ask it as lecithin also. So please don't get confused in that. So which of the following is deficient in this question? It is your dipalmitoyl phosphatidylcholine, which is your lecithin that is being deficient in this child, which is the main component of your surfactant. Okay, yes, we finished our second question. Next. This is mainly regarding the discussion regarding your respiratory distress syndrome. So the causes I have told already. One is your respiratory distress syndrome or your hyaline membrane disease. Second one, in term child, it is transient tachypnea of newborn. And third one will be your meconium aspiration syndrome. Meconium aspiration syndrome mainly in a this post-term children or in your term children also, you can have this meconium aspiration syndrome. Yes. Going on to this X-ray finding, this is an X-ray finding of a child with a respiratory distress syndrome. So what are the main findings you can see? There are four main findings. One is your air bronchogram. So air bronchogram is the RMR that is being indicated here. So air bronchogram is nothing but the air that is going till the level of your bronchiole. So whenever when your bronchiole or your bronchi is being obstructed at some place, when the air traverses through the trachea to your bronchi and bronchiole, you can see the passage of the air. That is called as air bronchogram. Second one is your whiteout lung. Third one is your ground glass appearance. Fourth one will be your heart margin and your diaphragm margin will be distorted. That is, there will be a blunting. So there will be a blunting of heart and your diaphragm margins. So these are the main finding in a child X-ray, main X-ray finding in a child with a respiratory distress syndrome. Next, this is an X-ray of a child with transient tachypnea of newborn. So the main four findings here will be, first one is your hyperinflation. Second one, there will be a fluid in your fissure, minor fissure. So this is a fluid in your minor fissure. So there can be fluid in your minor fissure. Third, there can be a pleural effusion. This red color arrow indicates a pleural effusion. Fourth point, there can be a perihilar streaks. These are the perihilar streaks or called as a sunburst appearance. These are the four main findings in a child with transient tachypnea of newborn. Why I am discussing about the X-ray findings? Because they can give you the X-ray findings. X-ray of a child showing a perihilar streaks with hyperinflation. What is your diagnosis? That can be a question also. So that time you should not get confused between your respiratory distress syndrome and transient tachypnea of your newborn. Oh. Next, these are the techniques in which you are going to administer the surfactant. Okay, this was your one of your innocent 2024 question also, right? Ensure is used. So ensure is used in mainly child with respiratory distress syndrome because it is a technique to administer your surfactant. That is, ensure is nothing but intubate, surfactant, and extubate. Okay, what is MIST? MIST is nothing but a minimally invasive surfactant therapy. It is a minimally invasive surfactant therapy. Next, LISA. LISA is nothing but your less invasive surfactant administration. And LMA is your by using your laryngeal mask airway, and this is your nebulized surfactant. These both are in your future advances. It is not yet being finalized here because here in this LMA technique and your nebulized surfactant technique, you can't estimate that all the surfactant that you are giving are going into the or distributed into the lungs evenly. So these three techniques are the main techniques that we are using it now. One is your ensure, next is your MIST, and next is your LISA technique. Okay, so this is about your techniques of your surfactant administration. Going on to our third question. This is also regarding respiratory distress syndrome. In a respiratory distress syndrome child, which cells are found to be defective? Which cell will produce your surfactant? It is your type 2 pneumocystis. So which cell will be defective? It is your type 2 pneumocystis. So the answer will be your type 2 pneumocystis. Okay, fine. Going on to your fourth question regarding your Apgar score. Apgar score of 3 at 1 minute indicates what? A, mildly depressed. B, further resuscitation not needed. C, severely depressed. Or D, normal. So what is Apgar score? So you know the mnemonic, right? A stands for your appearance, P for your pulse rate, G for grimace, A for activity, and R for your respiratory efforts. So the maximum Apgar score is 10. And the minimum Apgar score will be 0 also. Okay. So these are your maximum and minimum Apgar score. So coming on to the score. So first one regarding your appearance. 0 stands for whether the child is fully cyanotic or pale throughout. 1 stands for the extremities are blue and the body is pink. 2 stands for pink throughout. Next is regarding your, what is it? Pulse rate. Pulse rate or your heart rate. 0 stands for no heart rate. This 1 stands for heart rate less than 100 per minute. 2 stands for heart rate more than 100 per minute. Next is grimace. So grimace is when you leave this, what is it called, your nasogastric tube into the nose of the child, you are going to see the response. 0 stands for no response to the stimulation. 1 stands for weak cry on stimulation and the 2 stands for a very good cry on stimulation. Okay. Next is your A, activity. Going on to the activity, here the 0 stands for no activity and 1 stands for minimal flexion only, while the 2 stands for good flexion and resisting extension. Next is your respiratory effort. 0 is for apneic, 1 is a weak cry, and 2 is a very good cry. Okay, so this is how you score your respiratory, Apgar score. Fine. Yes. So when the Apgar score is less than 3, then the child is said to be, severely, the child is said to be severely depressed. More than 7 indicates normal. This Apgar score is mainly meant not for your resuscitation. It mainly meant for indicating the neonatal mortality. That way you have to remember it, because they can ask the question like Apgar score is mainly used to indicate what? Not your resuscitation efforts. It is mainly used to indicate your mortality, neonatal mortality. Okay. So going back to our question, Apgar score of 3 at 1 minute indicates a severely depressed child. So Apgar score, we score the child at 1 minute and at 5 minutes, and you have another terminology called as extended Apgar score. This extended Apgar score, we use this score at 20 minutes of life is called as extended Apgar score. So we can score the child with Apgar score at 1 minute, 5 minutes, and also at 20 minutes. So we have finished our 4th question. Going on to our 5th question. Here, a term baby on breastfeeding with a bilirubin of 14 milligram per deciliter. Which of the following is true or which you can give? 1 is your exchange transfusion, B is your continue breastfeeding, C phototherapy, and D stop breastfeeding. This is a term child, right? Okay. So the term baby can normally have a physiological jaundice. So when the child is having a physiological jaundice, you will not give your exchange transfusion. Yes. So this mainly this cutoff or everything is mainly based upon the treatment protocol is mainly based upon your AAP normogram. We have an AAP normogram chart. In that chart, you plot the day, that is the age of the child and the gestation of the child and the bilirubin level of the child. Whether the child is falling under the phototherapy range or in the exchange transfusion range, or no need for anything. So you are going to plot it in that chart, then only you are going to decide the treatment upon. So when they ask a question like this, general question like this, mainly when a child's bilirubin is more than 15 milligram per 15, more than 15 milligram per deciliter, the child will require your phototherapy. If it is less than 15, the child will not require even phototherapy. So you can continue only breastfeeding will be your answer. So going on to your neonatal jaundice, there will be a visible jaundice when the when the total serum bilirubin level is around 5 milligram. So 1 milligram of HB will give you 34 milligram of bilirubin. How is this bilirubin being produced? It is being produced from your heme. Okay, from heme, it is being converted into biliverdin. From biliverdin, it is being converted into bilirubin. This bilirubin is your unconjugated bilirubin. This unconjugated bilirubin is a it is a water insoluble one. It will be soluble only in the lipid. So since it is a water insoluble, it cannot be excreted in the urine very fastly, but it can enter your brain, that is blood-brain barrier. It can cross your blood-brain barrier easily. So whenever your unconjugated bilirubin is very high, it can lead on or it can produce what is called as kernicterus, that is bind, that is bilirubin-induced neurological damage. This unconjugated bilirubin, when it is taken to the liver, it is getting conjugated. Conjugated with the help of what? What enzyme? Just write it in the comment section. What enzyme that is being getting conjugated? So please be interactive also. So let us note it in the comment section also. What enzyme it is getting conjugated? Yes. Once it is getting conjugated, it is taken to your second part of your duodenum. From the intestine, again, there will be a recirculation amino in the intestine also. It is getting converted or deconjugated into your unconjugated bilirubin with the help of the bacteria that is being present in the intestine. So the unconjugated bilirubin, once again, it is taken back to your liver, that is called as your enterohepatic circulation. So next is your pathology. When will you call the child to have a pathological jaundice? So you can call the child to have pathological jaundice when the child is having a jaundice in the day 1. Okay. Second, on day 2, when there is an yellowish discoloration on till your legs and arm, then you can call the child to have a pathological jaundice. Third, any time when you observe a child, you are having an yellow discoloration over the palms and sole, then you can call the child to have pathological jaundice. 4, when the child's bilirubin level is more than 99th percentile, when you are plotting it in an AFP normogram chart. 5th, when the child is having the signs of bilirubin-induced neurological damage. 6th point, whenever the child's direct bilirubin more than 2 milligram per deciliter, then you call the child to have a pathological jaundice. Next, what is this instrument that is being shown here? It is your transcutaneous bilirubinometer. So this is your transcutaneous bilirubinometer. This transcutaneous bilirubinometer is mainly used for the children more than 35 weeks of gestation. 1. Next, it is like a screening method that is being used. Okay, whenever you start the child on with your phototherapy, you can't use a transcutaneous bilirubinometer. So after you start on a phototherapy, you have to check only the serum bilirubin, that is blood pricking the child. You have to use a total serum bilirubin level. You can't use a transcutaneous bilirubin. Only before starting the phototherapy, you can check this as a screening method. Third point, whenever the values in your transcutaneous bilirubinometer is between 12 to 14 milligram per deciliter, then you have to confirm it by using your serum level. Then you have to confirm by using total serum bilirubin. These are the main points in your child with transcutaneous, which child you're going to check with your transcutaneous bilirubinometer. This is your AAP normogram chart. I told you, the phototherapy cutoff range. So this normogram chart will include your gestation age. Second, it will include your age of the child. That is the day of the child. Next year, it will include your total serum bilirubin level. Fourth, it will include your this dotted lines. All it will include your risk factors. So there are 4 parameters. This your AAP normogram chart being included. That is, one is your gestational age, next is your age of the child from the birth, third one is your total serum bilirubin, fourth one is the risk factors. Okay, this is an AAP normogram chart for exchange transfusion. So sometimes they can ask a question like this: AAP normogram chart for exchange transfusion includes all of the following except can be also a question. Okay. Yes, coming on to your phototherapy. This is your phototherapy. So what are the mechanisms that is going on inside your phototherapy? One is your structural isomerization. Second is your photoisomerization. Third one is your photooxidation. Structural isomerization is the most important mechanism, right? In structural isomerization, your bilirubin is being converted into lumirubin, which is getting excreted in the urine. While in photoisomerization, your Z isomers are getting converted into E isomers. Right? Yes. The wavelength that is being used here is 460 to 490 nanometer. Irradiance is between 30 to 45 watts, nanowatts. And distance between your phototherapy and the child should be between 35 to 40 centimeter. And the light that you are using here is your LED light, or you can use your compact fluorescent light can be used, but LED will be more efficacious compared to your CFL light. So what are the complications you can expect in this child? Suppose when the child is having increased direct bilirubin, then you keep the child on with the phototherapy. The child can get what is called as your bronze baby syndrome. Second one, the child can have hypocalcemia. And third, the child can get hyperthermia with dehydration if the child is not being breastfed properly. So these are the main points regarding your phototherapy. Going on to our sixth question. Here, a 34 weeks gestation, the weight of the baby is 3 kg. That what are the child shows the following features associated with what? So a 34-week gestation with the 3 kg. That means the child is a LGA baby. That is a large for gestation baby. Large for gestation baby is associated with the mother with a gestational diabetes mellitus. So diabetes will be the answer for this question. I think I'll stop here with this question. Next, other questions I'll continue it in the next part. Thank you so much for your patience listening. Thank you.